dermatology. She is head of department of dermatology department in Vaishnampayan Medical College. A doctor by profession, yet a philanthropist by heart, with gold medal in dermatology and a YouTube channel. For this session, I would like to ask Dr. Vaijayanti Lagu ma'am to join the panel of chairpersons.
I'm the single bird outside this whole birds of same feather. I'm a different feather here, and I would like to thank Dr. Rai sir and all the organizing committee for giving me an opportunity to share my little knowledge on dermatology. Now, dermatology is purely basically photographs, so I'm sure I will not allow you all to sleep. Yes, next. Okay. At the outset, frankly, I want to tell you that I haven't seen any references of rheumatoid arthritis which have been, called for from dermatologists. So I have not seen any OPDs or references of RA, but yet I thought probably I will club all the different disorders or, differential diagnosis, and this is how we will discuss this whole scenario. Now, classification is primarily skin is a manifestation to any disease possible. So even if you have cholesterol high, your skin will speak. If you have anemia, your skin will speak. If you have rheumatoid arthritis, your skin will speak. If you have SLE, skin speaks. Vasculitis, skin speaks. So skin speaks love, skin speaks disease. How does the skin speak? So it could be just generalized manifestations. It could be RA related. It could be RA specific, or it could be the adverse reaction. Now, what are the generalized manifestation? If I ask in this panel, how many of you all have hair loss? So I'm sure 90% will say, yes, I have. Yes? Yes. If you say yes, probably you all are not sleeping. 90% yes? Men and women together. But that is a non-specific sign. That doesn't mean that you all have rheumatoid arthritis, isn't it? Dry skin, pale skin. This is very common discussion among the women. Why are you looking so pale? Or else, if you go to your mother's house, invariably, even if it is son or a daughter, the mother says, why are you looking pale? Your wife doesn't feed you? Is that so, Satyasham Teshniwal? Definitely such answers do come when the mothers say. The next is easy bruisability, generalized hyperpigmentation, erythema nodosum. So there are many lists of, non-specific skin manifestation, and not to forget the nails. See, now we cosmetologists, we apply artificial nails, we make our nails very beautiful, but actually nail also speaks a lot about the cutaneous manifestation in systemic disorders. Now let's go with different things. As we said, dry skin. See, the moment you see a dry skin, it could be ichthyosis, it could be psoriasis, it could be atopic dermatitis, or it could be drug-induced, that is lipid-lowering drugs. So any of these things can cause dryness. So no sooner you have a patient with dry skin plus arthritis, what are the differential diagnoses you would come up? You would come up with, most common, what you see in this particular case is psoriasis. So invariably they present to you as psoriatic skin lesions, but definitely if you ask an additional history, they will say that we have arthritis as well. Now, how are these scales? They are silvery white. Now, as I was listening to this, not only this forum, overall, everywhere the word used is rash. What is rash? There's nothing called as a word rash. Basically, these are cutaneous manifestations. So if we go back to our basics as a MBBS, we have maculopapular lesions, you have plaques, you have nodules, you have got exanthems, you've got purpuric lesions. So this is how we need to describe the lesion, but not as a single word, rash. Now, what are the lesions you are seeing here? They are multiple white, silver colored plaques. Yes? So this is a case of psoriasis, which could be a non-specific sign even in RA. Pehchan kaun, which is the first slide. Can I have the answers coming from the postgraduates? What are these lesions? Erythematous, flared up lesions. They are plaques. So that is nothing but urticaria. So urticaria can be a manifestation of SLE can be a manifestation of drug reaction. It could be a manifestation of rheumatoid arthritis as well. Dry skin, which is the commonest condition in India where you get dry skin. Hansen's, clofazimine induced dryness is very common. So no sooner you see a dry skin, you will have to look in for nerve thickening, and that is how these non-specific findings will definitely make you reach to a clinical conclusion. We cannot forget that we are in a country where tuberculosis and Hansen's still are prevalent. Though we are into non-leprosy eradication program, but yet we are seeing cases, so we should not forget it. No sooner you see a dry patch, you see a hypopigmented patch, you see a sensory impairment, just go for nerve examination. Nail. Nail speaks volumes about what is happening, whether it is clubbing, whether it is splitting, whether it is splinter hemorrhages, whether it is onycholysis. So these are the manifestations which also can be seen in rheumatoid arthritis. So these are all non-specific. Now let's move on to some related manifestation. What are these? They could be due to neutrophilic infiltration, that is Sweet syndrome, pyedoma gangrenosum, not very commonly seen. Granulomas, yes, definitely there are so many plethora of granulomas, which is the commonest one is tubercular granuloma, leprosy granuloma, then granuloma annulare, sarcoidosis. So these are very commonly seen. Next is erythema elevatum diutinum, livido and sicca. So just let's see what are these, how do they look like, how does a pyoderma gangrenosum look like. It's a very deep ulcer, it's its size is huge. So this is how pyoderma gangrenosum presents. Granulomas invariably present to us as like a plaque, and if you see the borders, you can feel the granules like, you can see like a nodule like feeling. So this could be presenting again in leprosy, it could be present in tuberculosis, it could be present in rheumatoid arthritis, it could be seen in palisading granulomas. So there are multiple conditions where you can see these conditions. So you have to correlate, it is not just one single finding, you need to correlate with multiple things. History, examination, and this is how you come to a conclusion, whether the person has arthritis. Now, all of us have been speaking livido, but until you see it, you will never understand it. So what exactly is livido? It's like, marble-like pattern, which you can see anywhere on the body. If you go to a neonatal ward, newborn babies, you will see invariably because of the temperature, the whole back is like livido. It's like, what you can say, marble-like appearance. So that is livido. Yes, when you give vasodilators, this livido will definitely reside. Let's move on to the specific cutaneous manifestation. What are they? One is rheumatoid nodules, nodulosis, accelerated nodulosis, rheumatoid vasculitis, and neutrophilic dermatosis. Vasculitis has been very beautifully covered with one of our colleagues, and I understood so many points because whenever I read vasculitis, I just go off to sleep. So it was a very wonderful lecture of vasculitis. Now let's go in for nodules. What are they? They are solitary, hard, skin-colored nodules, which is usually seen in the recurrent traumatic area, primarily forearm, elbow, finger, heel. But because of the latest evolution of DMARDs, definitely I'm sure you all must not be seeing this kind of nodules. So this is a actually borrowed Google picture because it is not seen nowadays. I'm not seeing it. So nodules again should raise a suspicion of Hansen's. So you can see very classically, there's a hypopigmented patch, you can see a nerve, you can see nodular lesions. So whenever you see a nodule, you need to suspect a case of Hansen's as a differential diagnosis. Now nodules are seen in dermatology, plethora of them. This is a case of hypertrophic lichen planus. So again this is like nodules. I want you to answer this. This was a 32-year-old male who came to us with this eruptive lesions. What is the diagnosis? And no sooner by diagnosis, we did some blood test and my physician, Dr. Shardul Kulkarni, gave the treatment and it started residing and it is totally vanished. Yes, quick, my time is running. Eruptive xanthomas. So these are theoretical part. I'll skip it. Vasculitis has been beautifully covered. I'll just show the photographs. So it can be presented as a palpable purpura. So very classically, when you do a test called as diascopy. What is diascopy? You just take a slide and press it. When you press the lesion, when the red color doesn't vanish, that is what is called as diascopy test. So that is positive. So no sooner diascopy is positive means it is a purpura and it is a palpable one. So that's a classical sign. This is a case which I have seen yesterday, which I was discussing with our nephrologist. Case of SLE, Dr. Wagh sir would be seeing it again. Young boy, you can see small pitted ulcers. He had lupus nephritis, which has been really managed beautifully with Holkar sir. He has got oral ulcers as well. So now I would like to start on rituximab, but I am skeptical. I need your guidance as a rheumatologist. If you all say yes, I would go ahead with this particular molecule in this case. Digital infarct, again, as ma'am has already told, calcium channel blocker is the best way and avoid cold. This is again a case of scleroderma, which we have seen in government hospital setup, which she has. She couldn't open her mouth. Luckily, she did not have any pulmonary hypertension, but she had GI disability. She couldn't eat properly. So we have given her infliximab and she has improved in her score, but her disease continues. We have put her on immunosuppressives, but she is doing well. This is again vasculitis. Many a times patients present to us either with arterial ulcer or venous ulcer in rheumatoid arthritis. It's a long term. So how do we manage these ulcers? Very simple, beautiful test which can be done in any government hospital setup also. This is called as PRF, platelet rich fibrin. So you just take the blood, 10 cc blood, you put it in a centrifuge, you allow it to settle down, a coagulum forms. The coagulum has to be just taken and put it in the ulcer area and it totally heals. This patient, it took around 8 sessions for us to heal this ulcer. So any non-healing ulcer, PRF is the beautiful answer. Now vasculitis, the mortality is pretty high. So I think we always need to take an opinion and start them on immunosuppressives. Sweet syndrome. So sweet syndrome is actually not sweet. It is a name given by the scientist who has discovered it. So you see multiple plaques. So again, I would request all the honorable forum to not use the word anymore rash, because we are not rash drivers. We are dermatologists and you are the best physicians. These are multiple plaques and nodules, and invariably it responds beautifully to dapsone. So this is very common association with rheumatoid arthritis. These are some syndromes where you can see digital infarcts, petechiae. This is EED, small vessel vasculitis. MONDORS disease, again on anterior thorax, this is very rare. By water, again you see small infarcts. Now here we have got a small instrument called as dermoscope, wherein you can diagnose at very early stage small infarcts. So this is how you could prevent this further progression. Reactions, definitely you all must have encountered much more, because we dermatologists give a very low dose of methotrexate, azathioprine and all these drugs. But one adverse reaction which I would always like to take home back is dapsone induced reaction, which is erythema multiforme, lands up with Stevens-Johnson syndrome. So always be very careful before you begin with dapsone. Just ask them, are they sensitive to sulfa group? Otherwise you may sometimes lose this patient, but this patient, fortunately, we could recover with cyclosporine. So these are the side effects, which is theoretical part I am not going to encounter. Okay. Now, this is again an autoimmune disorder, pemphigus vulgaris. Why I am talking about it? Because I always like to spread a word of mouth as to what I am doing. This is autoimmune disorder. Why am I presenting here? Because left and right I have been using rituximab. I have given more than 100 cases rituximab till now in government hospital setup without any ICU backup. So it's very it's not very scary situation when you try to begin with biologics. So start giving them, would be my request to all the youngsters. Please go ahead. And this is how a makeover journey of this young boy, which has happened in just 3 months. This is his back. He could not sleep. Obviously, you cannot expect him to work also. And he's not married even. And right now, he's on azathioprine. We'll taper it and he'll get married also. This is a young girl who wanted to commit suicide because of emphagus. And she's already married now. We have stopped her drugs. We have kept her under observation. This is a lady, again of emphagus vulgaris, wanted to go to Kedarnath, gave her rituximab, has been to Kedarnath, the prasadam has come back to me. So we need not go anywhere. We have to sit here and just do our divine job. And in the mid-age of my 40s, my undergraduate student forced me to begin my YouTube channel, and it has helped me to grow leaps and bounds. Because there is one specific work if you are doing in a particular thing, which is your area of core of interest, if you could just present that to the world. I have international patients from Mauritius, from Pakistan, from Bangladesh, from Africa. People call me to, treat them. Treat them only because I have reached them. So my earnest request to all the youngsters here, not only youngsters, all are young here, please choose an area of your choice and start presenting it to the world in a different way. Use social media platform not for your photographs, but use for your work. Because I would even ask Bichle madam to present her work on a social media platform, because we could help enormously. Right now, I always say that I'm in a divine circle to heal the pemphigus patients with lowest possible rituximab dose. So this is my YouTube channel. And this is, you can see, 24,000 views, sometimes 7,000 views. So whoever really wants it will reach you. When it comes to arthritis, there are non-medical people talking about arthritis, giving some oils which is not responding and taking the patient to a pathetic picture. Why not we? We have the knowledge. Why can't we present to this world all the knowledge on a platform? Because I am sure even if I die, this is going to stay, this is going to help people. I'm on a mission called as Mission Beauty Sundarmi Honarats. So I work in two worlds. One world is of disease and other world is of beauty. So definitely I would love all the rheumatologists to please send me a video as to what beauty means to you. Because in next 3 years, I would like to make 1 lakh women beautiful. Thank you so much.
Wonderful presentation.
Thank you very much, ma'am, for such an illustrative and beautiful lecture and excellent oratory skill.
Any questions? Anything from the audience? Thank you.
I would like to ask chairpersons to felicitate Dr. Smita Zakotula.